the University of Arizona Bio5 Institute, we bring together hundreds of multifaceted experts that include world-class bioscientists, engineers, physicians, and computational researchers. This team science approach is designed to ignite creative solutions to the many complex biological challenges facing our families and communities, and has resulted in disease prevention strategies, promising new therapies, innovative diagnostics and devices, and improved food sustainability.
Hello and welcome to another episode of Science Talks, a conversation hosted by the University of Arizona's Bio5 Institute. My name is Lisa Romero.
And I'm Brittany Ulorn.
Treatment for patients with blood cancers like leukemia or lymphoma may include a bone marrow transplant to replace unhealthy tissue in order to increase odds of recovery and survival. Transplants can be life-saving, but are complex and challenging, especially in the case of children. Today, we are really happy to be joined by physician scientist, Dr. Emmanuel Katsanis, who not only performs transplantation. Dr. Katsanis is a professor of pediatrics, medicine, immunology, cancer biology, and is a Bio5 member. He combines his 3 decades of expertise in the lab and clinic as the director of the Blood and Marrow Transplant Program and Division Chief of Pediatric Hematology, Oncology at the University of Arizona, as well as directing his own research lab. We're excited to talk more with Dr. Katsanis about his research in pediatric clinical care, as well as advancements in transplantation. Thank you so much for joining us today.
Thank you for having me.
So like Lisa mentioned, you are a physician scientist, so you provide care for children with cancer and blood disorders, and you also conduct research at the University of Arizona's Steele Children's Research Center and the Diamond Children's Medical Center in Banner. So can you tell us a little bit about your research and how your work at both the bench and the bedside kind of talk to and impact one another?
So my research has always been driven by my clinical experience. I started as an MD and then did my training in pediatrics in Canada. And then from there went to the University of Minnesota, where I trained in pediatric hematology oncology. The first year in my fellowship was clinical, but we were required then to spend some time in the lab, which for me, when I first went in the lab, I thought I was starting kindergarten again at that time. But with time, I got to enjoy what I was doing, and especially with projects that I found to be more clinically relevant and translational. I ended up doing 3 years in the laboratory there, and then stayed at the University of Minnesota and had protected time. So my research experience improved significantly. So, coming to Arizona, I continued in the same area, which was tumor immunology back in the time where most oncologists were making fun of us, that the immune system would never be able to have an effect against cancer. But as a clinician, I was a bone marrow transplant physician, and we had seen with graft versus host disease the effects that we saw in patients. When someone has graft versus host disease, they usually have some graft versus leukemia or graft versus tumor. So my lab has continued, through the years in these areas, with progress in some and not so much in other areas. But a lot of what we've done has moved into clinical trials, and especially in the last few years in bone marrow transplantation, work that we did back in 2015-16 in mice is now an ongoing clinical trial here at the University of Arizona, with the hope of it soon to become, if I get the funding, a multi-center phase 2 clinical trial. I could talk a little bit about that trial if you would like.
Sure, that'd be great.
So being in Arizona and having a large minority population or large minority populations, we have a difficult time in finding a matched unrelated donor. So you would prefer that someone would have a matched sibling, but the chances of having a matched sibling is 1 in 4. And with smaller families, we don't often have a matched sibling. So we used to do transplants with looking for unrelated donors in very young kids, potentially cord blood transplants as donors. But if you're, let's say, for example, Hispanic of Mexican background, the chances of finding a matched unrelated donor is only about 37, 38%. If you're African American, it's only 17%. So having minority patients, we often had to use unrelated donors that were not fully matched, HLA matched. Haploidentical bone marrow transplantation was done back in the years that I was in Minnesota in a few centers, but it was problematic with a lot of complications. But with work that was done primarily at Johns Hopkins, more recently, again, starting in mice and then evolving into humans, they found that you can take a half-matched donor called haploidentical, and in pediatrics, parents are always a half-match with their kids. As we mentioned, siblings have a 25% chance of being a full match, but also have a 50% chance of being a half-match. So within the family, you pretty much always find a donor. So this was very important to implement here, which we have. The protocol that we initially used was a little bit different than Johns Hopkins in terms of the conditioning of the transplant, which for pediatrics was more intensive. But the question that I asked at that point was, why are they using cyclophosphamide following transplantation? We know why they were using cyclophosphamide following transplantation was because the alloreactive cells from the half-match, the haplodonor, proliferate once they're infused into the patient. And if those alloreactive cells are not eliminated, the patient is likely going to die of graft versus host disease. So work that they did in mice, they found that you can give chemotherapy following transplantation, and that would eliminate most of the alloreactive T cells, but would not kill the stem cells. So the mice engrafted and had protection against graft versus host disease. So the question that we asked, why cyclophosphamide? Is there another drug that may be better? So we studied a variety of different agents and found that a medication that was used mainly for adult certain lymphomas and leukemias was equally effective in suppressing graft versus host disease and allowed better graft versus leukemia effect in these mice. So mice did not die from graft versus host disease, and then they survived and they were able to eliminate the leukemia, whereas the mice that only got the cyclophosphamide died of leukemia. So we then proceeded to a clinical trial, and obviously you can't move to humans and do exactly what you did in the mice, so we had to do a phase 1 study where we slowly decreased the amount of cyclophosphamide and replaced it with bendamustine. And we have done different cohorts, reaching cohort number 4, where we had replaced day 4, one of the days of cyclophosphamide, and we were starting to replace the day 3. We found that just replacing one day, the day 4, with bendamustine and giving cyclophosphamide day 3 had the best results. The patients that received that engrafted significantly earlier. They tended to have less infections, and especially CMV, which is a virus that reactivates after transplantation. And all 3 patients are alive and disease-free from 2 to 3 years after transplantation. So we now have moved to a phase 1B, where we're doing a larger cohort of patients on this dosing. And we're waiting to hear if our NIH submission will get funded, which will expand to a multi-center trial, which will be randomized between patients getting only post-transplant cyclophosphamide versus cyclophosphamide and bendamustine.
Wow, that is, you know, the word hope comes to mind there when you talk, you know, amongst the clinical and scientific terms. I mean, I'm a parent, and, you know, those words to me mean hope for, you know, so many parents and children. So, you know, thank you for that. I think the question that comes to my mind, and we ask this a lot of our guests, but I think in your case, it's even a more unique question because you so clearly see the effects of your research having that hope impact, you know, on your patients. And you know, there are a lot of researchers who are very invested in their work and really want to, you know, make a translation possible, but don't do that themselves. So I think my question to you is, you know, how does that translate into what is the most challenging thing about your job? And then, you know, what is the most rewarding based on the fact that you're juggling those two roles?
A lot is
loaded question.
a lot is challenging. I think most of it is time, because, you know, I'm very committed to my patients. I pretty much attend almost every day. I'm finally starting to get some help with some of my junior faculty that are covering some weeks, you know, of the year on the transplant service. You know, we're not a huge center, which has allowed me to be able to do, you know, this much clinical. It's usually my mornings. That's how they start, by seeing you know, the patients, and then in the afternoon is more research and unfortunately a lot of administration from all the things that I need to do. But what I love doing is seeing the patients, you know, seeing how they do, making sure I do a good job, making sure they're happy, and especially the parents, knowing that, you know, me and my team have done everything that we can do. And fortunately, the results have significantly improved from the years that I've been doing this. And, you know, with most of our patients, meaning that 75 to 80% can be cured with, you know, whatever disease they have. You know, the most common are leukemias, acute lymphoblastic and acute myeloid leukemia. But we also transplant patients with congenital anemia, sickle cell disease, for example, acquired blood disorders like severe aplastic anemia, but also infants that are born and the parents find out through newborn screening that they have no immune system. And we've had a couple in the last 2 years that were transplanted a few months of life and are now, you know, a year and a half out, and you know, are healthy and doing well. So knowing that this was a lethal disease that now you have cured is obviously, you know, very, very rewarding. So as you can imagine, it's hard to give up any of the things that I do, because again, you see what's happening clinically. You know, you can't cure everybody. You know, there are still issues, and you then have the drive to go back in the lab. Fortunately, I'm not alone. I work with other scientists, you know, over the years. And I've had, you know, postdocs and junior faculty members in my laboratory of diverse backgrounds. Currently, I'm working very closely with Dr. Ricky Simpson, who's an immunologist, actually an exercise immunologist. So we have found, you know, with our passion in running, but also in immunology, a lot of common areas. So our labs are collaborating very closely, and especially with the viral infections and viral reactivations, because he has done a lot of work previously in that arena. So the patients that I mentioned in the clinical trial, we brought back from the clinic so it started from the bench to the clinic, and now we're studying these patients because we get samples at 30 days, 60 days, 100 days, 180, and 365 after transplant, and looking to see how their immune system reconstitutes compared to the controls that get the other therapy. So we're learning how the immune system may be benefited by this approach.
That's a really special thing to be able to say. I don't think there's a lot of people that are able to see that sort of full circle approach to science and medicine. I tell everybody my favorite part of my job is, being able to talk with and share the stories of people like you who are truly dedicated to making a difference in the world. But I mean, you literally put that into play every day. So that's pretty incredible. So taking a little different tack, although it resounds with that comment, we've talked to a few physician scientists that are our Bio5 members. One is the former director of Bio5, Fernando Martinez, and we were asking him about his path as well, and his ability to sort of juggle the physician scientists. And he said he wouldn't trade it for the world. He, like you, I think, eats, breathes, and sleeps the circular version of what you just described. And he said it's a hard road for the next generation, but he encourages people to really seek out those types of opportunities. Do you have any sort of words of wisdom to people considering that very difficult path of like you said, you thought you started in kindergarten again? Any words of wisdom for people thinking about doing both?
Yeah, things have really changed from when I started, right? It's been many years. I started my residency back in 1983. So I've seen the field change, and obviously I've been in different countries doing this. But yeah, that is my biggest worry, that the physician scientists, especially with the funding of where it is becoming almost extinct. We do have a lot of pressures where our salaries come from. I've been fortunate to be supported, by an endowed chair, that helps offset some of, the clinical work, even though, as I mentioned, I see patients virtually every day. But things have changed, and someone starting back when I was starting, that you wrote an NIH grant and you had 1 in 4 chance of getting funded. That has really changed. So even though I know more and I'm smarter, it's harder to get a grant now than it was 15 years ago. But there are, I'm on the P&T committee in our department. Actually, I chair that committee, and I'm on a task force for the College of Medicine, and we just had a meeting today, discussing how do we promote, not necessarily tenured professors, but at least a track that people can be motivated to work with scientists. Because what you don't want to happen is to have physicians just look after patients and not interested in the science. It's very important to have that phenotype that is interested in both, even though they may not be able to run their own lab. So I think there needs to be a focus in being able to promote that, so the scientists could have a partner that has an interest to see things move forward. And if someone is exceptional and can get grants, then for sure you can have the 10% clinician and 90% physician, 10% clinician and 90% scientists, which again, that's what's slowly being, is slowly disappearing.
Yeah, that's you know, so much a focus of conversation in a place like Bio 5 as well, obviously, and why our physician scientists and telling their story is important to us because again, you see the results in a more profound way come to light. And so we, you know, like to support and hopefully continue to support those efforts because it is an important piece of scientific progress and medical progress. You mentioned your you know, international background a little bit, and I know you are from Greece, I believe, and lived in Canada, and you know, I know you've been here for a while, but how do you think that global perspective, you know, sort of helped you as well in terms of you know, just your scientific and medical goals, but also just life in general?
Yeah, I was actually born in Canada.
Oh, I'm sorry, I reversed that.
Yeah, Quebec City. My parents immigrated. My mom was 7 months pregnant when she took the boat from Athens and landed in Halifax, Canada.
Oh, wow.
And I was born a couple months later in Quebec City. I grew up in Montreal. There was a, you know, pretty large community. You know, my parents immigrants in a strange cold country in the 1950s. My mom was the driving force in sort of pushing me in school. I started off in going to a Greek school in the church in Montreal, where it was half Greek, half English for the first 3 years. And then obviously after 3 years, it was all English. So when I was, after I finished the 9th grade in Canada, my parents, I was 15, they said, we're moving to Greece. So initially it was a shock, but I feel that those were the best years of my life growing up there. I started running track when I was in school, and actually became the Greek champion of 800 meters when I was 16 for 16 and under. And but again, as I mentioned, the push was to get into medical school, which I wanted. And in Greece, it's very difficult, a lot of entrance exams to get in. And I managed to get in, and running then had to disappear from my life because it was too difficult to continue on. Initially, I thought I would want to do hematology, basically because I saw a lot of kids that had thalassemia, which is a congenital blood disorder that you need chronic transfusions. Finishing my studies in Greece, I came back to Canada, did my residency I started in Montreal, then went to Ottawa. And when I rotated through hematology oncology, dealing with the kids with cancer was where I found I needed to be. You know, I had some patients that I looked after that I bonded, you know, very closely, and very difficult when you're young to see, you know, your patients die. And so from there on, that's what I wanted to do. And I moved to Minnesota mainly because it had a very strong bone marrow transplant program. So I think seeing the different healthcare systems, you know, the different problems have put you know, I have a sort of a different perspective. I see the pluses of Canada, the universal healthcare, especially when we're dealing with kids with cancer. And sometimes you have to fight with insurance companies here to even get a CT scan. But then, you know, there are some negatives. But when you're dealing with pediatrics, I don't think having universal healthcare, there's really any negative. So it has broadened my perspective. You know, I've had kids here. One was born in Minnesota, my daughter, and my son in Tucson. And I sent both my kids to study in Canada, and they ended up liking it, and they're going to stay in Canada. So talking about full circle, you know, even in that, and it's because they saw the perspective that I had in life, and being worldly in terms of how you see everything, and they had that perspective, and they adjusted very easily. You know, they live in Toronto, which is a very diverse, city. 57% of the population has been born outside Canada that lives in Toronto. So, so I'm glad that I was forced to move to Greece. It really impacted, all avenues in my life.
Wow. That is such an incredible journey. And it's clear how, living in Canada and Greece and then coming to the US, how it's really just diversified your perspective on medicine and science and life in general. And that's neat that you're able to, instill that in your children as well. I think it's something that not a lot of people get to experience. A lot of times people are born in one place and they stay there. And it's neat that you've been able to be all over the world and share that with your kids. So kind of going off of something that you were talking about, your passion for running. So I know from your Twitter, you did find your way back into running, even if you had to let it go when you started med school. So I want to know, can you talk to us about how having hobbies like running and passions like running outside of a demanding job are really important to keeping you mentally and physically healthy?
Yeah, I mean, that's my second passion. So I get up 4 o'clock every morning. I started a running group when I first moved to Arizona. We've named our group the Interloopers. We meet from 1998 every Tuesday and Thursday at 5 o'clock in the morning in one of the tracks in town. And then on the weekends, we run a long run. So the group has continued from 1998. Most of us have aged and have gotten slower. We have quite a few younger members. And, as I've gotten older, I've gotten slower, and the younger members that were slower are now surpassing me. And even some of the women are passing me. But as most of my younger, friends that run, I'm very much into data and graphics. So I make sure if I lose from them that I age grade the performance, and I send them a graph that I'm still better, even though I was a mile behind them. So, so that is, that's what keeps me sane in having this group. And there's people from all over, not only medicine, actually very few are from medicine. And it's been a stable group that we've had, and everybody's welcome to join. We don't charge anything. And if you're looking for company to run early in the morning when it's dark in the winter and cool in the summer, then that's the place to be.
That sounds like a lot of fun, except for the time. You have to be very, very dedicated, as clearly you are. But that's amazing. I'm sure you've not only had the comfort of this group that shares similar passions, but I'm sure many of those have turned into long-term friendships and a support network, which is really important in a demanding job like yours. So that's very cool.
It has been especially important, with the pandemic.
Yes.
That has been, for a long period of time, our only outing, to be able to go and run with a group. My wife, Lucy, runs with me. She's a few years younger and she's caught up. So my motivation now is not to fall too far behind my wife. And she's also a nurse practitioner here in pediatric oncology. So, we also work together and we run together, and we obviously, live together. So it's been, that's why I haven't left Arizona. There's so many things to do. It's a great community, great collaborations. You can do great science. You have everything here. You don't need to be, in huge centers in big cities. And I don't think there's many places, in the world that you can do what we do here.
And get up at 4 or 5 a.m. and be able to run outside.
Yeah.
So we want to thank you for your time. We like to end these episodes asking a kind of a silly question, but one that we think is important. We think all of our scientists and physicians and researchers are superheroes already. Everything that you've talked about today lends itself to the word superhero. But if you weren't who you are and hadn't accomplished what you've already accomplished and hope to accomplish in your lifetime, what if you could choose to be any superhero, what would your superpower be?
I guess with everything that I've talked about.
Sleeping, getting some rest.
Maybe being able to touch a patient and kill every last cancer cell in their body really, really fast, age graded or not.
I love that, combining your two passions for what you do at work and running. That's perfect.
Perfect.
Oh, well, thank you again, Dr. Katsanis, for joining us today. We so appreciated your conversation and, hearing about what you're doing in the clinic and in the lab and, your journey all over the world and running through Tucson. So we really appreciate you being with us today.
Thank you for having me. I really enjoyed this.
Of course. And thank you to our listeners for joining us on another episode of Science Talks. For more information about the Bio5 Institute, please visit our website at bio5.org. And from all of us at Bio5, we will see you in the next episode.
Thanks to our listeners for tuning in to another episode of Science Talks. Continue the conversation with us next time as we learn more about the amazing science happening at the University of Arizona's Bio5 Institute.